help us and get involved. Thank you. Okay, I'd like to introduce Dr. Bobby McFarland, who heads up the service, Mitochondrial Specialist Service in Newcastle. Bobby's going to talk to you about the importance of monitoring in mitochondrial disease, and then he's going to go on to talk about supplements. Thank you, Bobby.
Great, thanks very much. And thanks to everyone for coming to what's a fantastic weekend. This is the 6th, is it, of these? Fantastic event, and really nice to be here to share this with you. So last year I talked and went hopelessly over time. I had the wrap-up sign about 3 or 4 times before I finally wrapped up. This time it's going to be a bit more punchier. So we're going to do some short talks, 10 minutes. There will be time for questions, but I've seen the agenda now, and actually there will be time at the end of this first session for questions on all speakers. Okay, so I've been asked to talk about monitoring, why we monitor mitochondrial disease, and when we should monitor. So just to recap, this is a whole weekend about mitochondrial disease, so you're going to have lots of recaps about what mitochondrial disease is. So basically, mitochondria are responsible for converting food into energy that cells can use. How do they do that? Well, the machinery is very complex, and I'm not going to go into all of that just now. Safe to say that it's this bit here that does that, essentially. A little bit more simplified. Mitochondria, lots of energy in. What happens when that energy is reduced, when mitochondria aren't working well? Well, when they're not working well, because mitochondria are present in almost every cell in our bodies, there's a potential for all sorts of organ systems to go wrong. And this diagram, you'll not be able to read it at the back, but it's really just to illustrate the fact that so many different organs in the body can be affected by mitochondrial disease, and not just different organs, but different combinations of organs. Okay. But mitochondrial disease does tend to affect tissues and organs with a very high energy demand. So tissues like muscles, we see myopathy and weakness. Tissues like brain, so we see encephalopathy or brain dysfunction and epilepsy. And that's because those particular tissues have a really high energy demand. The brain consumes about 30% of the energy that we actually generate. And mitochondrial disease is complicated, so it can affect any particular organ, and there can be all sorts of combinations of organs involved. But even when you know the genetic fault, there can be huge variation in how that disease presents. And these 4 individuals, I'm sorry, it's been chopped off a little bit at that end, but these 4 individuals all have the same genetic fault, and it's a deletion in the mitochondrial DNA. This child is presented with Pearson syndrome very early in life. This gentleman's presented with a little bit of drooping of his eyelids and restriction of his eye movements in his 60s. And these 2 males in between, I looked after Luke for quite a number of years. He was very severely affected by his mitochondrial disease. And this gentleman still comes to the mitochondrial clinic in Newcastle and has been doing so for 30 years, despite the onset of disease in childhood. So there's huge variability, and it is very difficult to generalize in mitochondrial disease, is the point. And that leads me into why we should monitor. I've said that mitochondrial disease can affect any particular organ, and some of those organs can be affected in a way that's treatable. So it's really important we know about the conditions that we can actually treat. monitoring also improves doctors' understanding of mitochondrial disease and researchers' understanding of mitochondrial disease. So it's important from that aspect that we are learning all of the time about mitochondrial disease. And this thing that's typed on at the end is just gone off as a thing called natural history. So this mitochondrial disease isn't one disease, it's lots of different diseases. And it's important that we document the natural history for these different diseases and learn about how each of them unfolds with time. And the last thing I put up there is trial readiness. So it's important to know where you are in your mitochondrial disease story in terms of your readiness and appropriateness for being entered into a clinical trial. How clinical trials are run is really to minimize variation. So if you have a particular drug that you want to test, you want to test that on people who are actually very similar. And recruiting people into clinical trials, there are a lot of exclusion criteria and inclusion criteria which define the people that are enrolled in that clinical trial. And that process is largely to minimize variation so that you know if you give the drug to those people, the effect that it has is not due to variation between those individuals, but because the drug works. So, what do we do in terms of health surveillance? Well, we're not looking over your shoulder, seeing exactly what feeds you're giving to your child, or are you giving their anticonvulsants every single day at the appropriate times. It's not about Big Brother kind of scenario. What we're interested in largely are those organs that have got high energy demand, so cardiac tissue, endocrine, hearing impairment, visual impairment, epilepsy, and dysphagia. Those are the sorts of things that are fairly easy and readily monitored. And why do we do that? Well, let's start with the cardiac. Mitochondrial disease can affect the heart in several different ways. It can affect the rhythm of the heart, or it can affect the pumping power of the heart. We would often ask a cardiologist to be involved in terms of managing patients with cardiac complications, and we'd suggest that an ECG is done once a year to look at the rhythm of the heart. And this is an ECG of a patient with a particular rhythm disturbance called Wolff-Parkinson-White. And that monitoring every year can pick up changes in that rhythm or in the rate of the heart. So if their heart's beating fast or slow, you can detect it clinically, but you can also confirm that on the ECG. And there are some symptoms that patients might present with or their parents might see in these children: palpitations, heart beating very fast, and awareness of that, shortness of breath, slow or fast heart rate, or indeed chest pain, which is a rare problem in children. And the point in doing that monitoring is that you can treat rhythm disturbances. You can treat them with a tablet that such as a beta blocker or another drug called verapamil, which will slow the heart down, and correct the rhythm disturbance. Or indeed, in severe cases, you may need to put a pacemaker in to pace the heart if the rate of that heart is too slow. And sometimes in this particular condition, Wolff-Parkinson-White, there's a little aberrant pathway in the heart, and that needs to be ablated. In terms of the power of the heart, the other thing to say is ECGs are cheap, and so actually having it done once a year, not a big ask of the NHS. You're not going to drain the resources by having an ECG once a year. Echocardiogram's a little bit more expensive. You have to have a technician, with this particular skill to do it, but very well worth it. So just to orientate you, this is a normal heart. So there are two chambers at the top, two chambers at the bottom. These chambers at the bottom are the ventricles, they're the big pumping chambers. This is the left and this is the right. This is the one that pumps blood out to the body. Okay, so it's a bit bigger. This one pumps blood to the lungs. Doesn't need to be quite so big. Could you just click on hypertrophy? So mitochondrial disease, as I say, the heart is absolutely packed full of mitochondria. Oh. Okay, so heart's packed full of mitochondria, and in some mitochondrial diseases, the heart is involved and it thickens. So it pumps. It's not pumping as effectively as it should, so it tries to pump a bit harder. And if those of you who go to the gym will know that if you repetitively pump your muscles, they get a bit bigger. I've never been to the gym, so... And that's exactly what's happening here, is that you can see this left ventricle is now much, much thicker. This is the ventricular wall that separates the left and the right ventricles. And it's pumping, but it's pumping much less effectively. Only a small volume of blood filling the chamber and then being pushed out. And if that process is allowed to go on, eventually the heart gets to the stage where it just gives up. And you get what's called a dilated cardiomyopathy. And you get this large ventricle that's basically not moving very much at all. And so there are opportunities here to prevent going from a normal heart to a thickened heart, and also from a thickened heart to a dilated heart. And that's through picking this up early. It's not something that's terribly symptomatic, certainly not in the early stages. And by that I mean you won't know that it's going on. So this can be occurring insidiously. So you wouldn't pick it up unless you actually look for it. And that's why when patients are diagnosed with mitochondrial disease, we recommend that they have an echocardiogram at baseline at diagnosis, and then after a year, and after a year annually for about 3 years until a cardiologist is happy that there's been no progression, and then the period can be extended.